Now I am going to announce the next talk is Dr. Deidi Bergestuen, who is an MD, PhD, an internal medicine physician and lung cancer survivor. She received her MD degree from UT Southwestern in 1994, completed her medicine residency in internal medicine in 1997. In 2001, she married a Norwegian and thus moved to Norway to start her practice. She took a gastroenterology fellowship at the University of Oslo and completed a PhD there as well in 2010. Her resource focused on epidemiology and fibrotic complications of intestinal neuroendocrine tumors. In 2011, she returned to the U.S. because unfortunately she was diagnosed with metastatic lung cancer. She now has undergone treatment and she's looking forward to her practice as she has restarted her practice of gastroenterology. We now welcome Dr. Deidi Bergestuen.
I am so thrilled to be speaking to you at this wonderful conference, the Summit at the Summit Conference. I wish so much that I could have been here to give this presentation to you in person today, but I just went back to work after a 3.5-year hiatus from medicine, and I'll give you the reason for that pause in a little while. I know that you are here looking for answers for the complex problems facing American healthcare. I don't have any answers, but I do have a unique perspective that I can give, and I hope it will be of encouragement and interest to you. I'm a medical doctor. I have a MD, PhD. I had the opportunity to live and work in Norway for 10 years. I moved there in 2001 with my husband, who is from Norway, and it was a fantastic experience. Norway is such a beautiful, wonderful country. Therefore, I have experience in both the U.S. and Norwegian healthcare systems, and we'll contrast them a little bit later. I'm also a patient, and I am a 3.5-year survivor of stage 4 lung cancer. And it's a miracle that I'm even here today, able to speak to you 3.5 years later. And I will share a little bit more about my experience as a patient in a few minutes. Let me give you a little bit of my background. I went to college at Texas A&M University and graduated in 1994 with a degree in history. I went on to medical school at University of Texas Southwestern Medical School in Dallas and graduated there in 1994. When I was living in Norway, I had the opportunity to complete a PhD, and this was completed in 2010. My PhD was concentrated on the fibrotic complications of small intestinal neuroendocrine tumors. Here you see a picture of my 3 opponents, and I'm smiling because I'm finished. It was a great day. I completed a residency in internal medicine here in the United States before I moved to Norway. The first 2 years I carried them out at the University of Texas Southwestern Medical Center. And then my 3rd year I completed at State University of New York in Syracuse. I moved up there my 3rd year of residency because I had just married and my husband, Tron, was attending college at Ithaca in New York. When I moved to Norway, I had the opportunity in 2005 to begin a fellowship in gastroenterology. And it was during these 6 years as a gastro fellow I completed my PhD. And 4 of those years I was able to work 20% of the time as a physician and then do research 80% of the time. And a wonderful aspect of getting a PhD in Norway is that I had a salary. Previously, before I moved to Norway, I was attending at the University of Medicine and Dentistry in New Jersey, and I was a clinical assistant professor of medicine and was responsible for the teaching clinic, and that was a very interesting job. And then here are some pictures from my colleagues in the Division of Gastroenterology. Here we are at Morning Report, and the next 2 slides are the time that we were evaluated to become a European Center of Excellence in the treatment of neuroendocrine tumors. These are very rare tumors, and they were concentrated in our hospital as well as a few other university hospitals in Norway. Along with several other physicians, I was responsible for these patients. We did receive this designation as a European Center of Excellence for Neuroendocrine Tumors, and that was a great day for us. Let me tell you a little bit more about Rikshospitalet. First, you can see a couple of pictures of it. This is an aerial view of the hospital, and it's connected to the University of Oslo's medical school. I love this picture from inside the hospital. It's a very modern hospital, and this is a central hallway. And you see the beautiful stained glass windows at the end of the hallway or atrium. And when the sun is shining through there, it's really beautiful. Rikshospitalet is a university hospital, and as I mentioned, it is associated with the University of Oslo Medical School. It's a large hospital for Norway. It has 568 beds, and it is only a tertiary care hospital. It's responsible for transplantation for the entire country, as well as for very complicated patients, and sees patients with very rare diseases. Patients from all over the country are referred to Rikshospitalet. Being a country of 5 million people, you have to centralize very complicated very complicated type treatments such as transplantation. And so Rikshospitalet again takes care of these types of patients on a national basis and is the national referral hospital. So with that as a little bit of a background, I wanted to try to contrast for you the systems between the U.S. and Norway. Let me say I loved working in Norway. It was a great place to be, very exciting. I had wonderful colleagues, a wonderful hospital to work in, and it was great to be able to do some research as well. So part of the crux of the problem for the United States, it will be in the coming years' economy. And I wanted to just contrast these two countries, and the difference is amazing. Unfortunately, as you all know, we have a terrible debt in the U.S., $18 trillion as of June of this year. That means that every one of us owes $58,000. Norway, in contrast, has always a budget surplus, and this is because they have vast oil reserves off the coast. And in 2013, for example, their GDP was over $5 billion, and they had a budget surplus of 11.3% of this amount. Norway has also been extremely successful and fair in managing their oil fund, and the oil is for everybody, and everybody benefits from it all the time. And in their oil fund, there's $165,000 for every Norwegian. That is just amazing to me. What is it like in Norway as far as their health system? As I mentioned earlier, it is a socialized healthcare system. The primary care doctors are all family practitioners. There are no, for example, primary care internists, and there are almost no private clinics, but there are a few. And then you have inpatient care, which would be all of the specialists, including general internal medicine physicians. There are clinics, of course, at the hospital, and family practitioners refer patients into the hospitals, but they themselves never have patients or patient responsibilities for inpatients. They also, of course, have emergency rooms, and they have a very good system of step-down emergency rooms, I call it. And these are acute care centers. And I love the Norwegian language. It's very descriptive. And these acute step-down ERs, as I call them, are called legevakt or doctor watches. this helps keep the ER free of mild cases such as colds or an ear infection and so forth. And this is a very good system of protecting the emergency room and keeping it open for really acute emergencies. So in Norway, let me go a little bit over pros and cons. Well, in Norway, they have much less bureaucracy than we do. That has to do with the fact that there are no insurance premiums. Everybody is insured, so you have a lot less administrative costs as far as the practice of medicine, though there are a lot of rules and regulations. And one important thing is that the ERs are not used as primary care clinics, and that is a very important thing. Everyone has a primary care doctor, a family practitioner. They are assigned, or they can pick who they want, but they have to have a primary care doctor. Also, of course, Norway is very advanced in research and technology. A problem, though, is that you cannot choose your doctor. For example, if you are referred into the hospital for a surgery, an elective surgery, for example, a cholecystectomy, you will be referred in and you will be given an appointment first at the surgery clinic, and the doctor will be the one who happens to be there that day. When you are operated on, it might be a different physician. So that's a little bit of a problem because this creates a lack of continuity of care, and the patients are constantly having to give their patient history over and over. So that is a problem. It's interesting, this is actually being addressed. There was recently, in the past few years, a medical doctor who was diagnosed with colon cancer, and he has been very bold and been in the news about his experience of having multiple physicians in his care, in the care of his case, and how he would constantly have to give his history over and over. So they're trying to address this, and that is very good. Another problem is that sometimes Norway may not be able to cover an advanced treatment that is available outside of the country, but that is not yet available in Norway. That's always a big debate as well. Should this procedure be covered, or should it not be covered? There can be a significant wait time for elective procedures. And I had a case like that, though this was very minor, but I did have an inflamed bursa on my foot, and I was referred to the clinic at the hospital for possible correction of this problem. And I was given an appointment for 6 months later, and by that time the inflammation had resolved. So for elective procedures, there can be a significant wait time, though of course they're always trying to work on it. Now we have many pros as well in our system, of course, and I only listed 3 here, but one nice thing is that we can choose our physician, and usually there is pretty good continuity of care. We of course have very advanced research and technology as well. But we all know that a problem is we have very complicated coverage with regard to insurance. There are multiple providers, some are private, some are public. Because of the complicated regulations and the increasing regulations, we are having to employ more and more administrators and people who are not treating patients just to take care of the rules and the insurance regulations. And that is increasing costs without affecting patient care. Let's look a little bit about how much Norway and the U.S. spend on healthcare. Well, I've always been taught that the U.S. spends the most in the whole world, and that is true, we do, but there are many countries not far behind us. If you look at this graph from the World Health Organization, this is looking at per capita expenditure on healthcare. And the U.S. is in the lead, $8,299 per capita. But look at the second place, and this is Norway. So I thought that was interesting. And I took this slide off of a site called Business Insider, but it is from the World Health Organization. If you look at healthcare costs as a percentage, however, of GDP, we are way up there. And you see how Norway is about half as much as compared to us when it comes to their healthcare cost as a percentage of their GDP. So we are way up there over other industrialized nations. What do we get for our money? Well, we're not doing so well. If you look at this graph, and this is from a book called, I'm going to have to look at the title here, National Research Council and Institute of Medicine. And if you look at deaths from all causes, we are at the bottom compared to other industrialized nations. And look at this graph. We have a real problem with infant mortality compared to other industrialized nations. So why do we have this so-called U.S. health disadvantage? Well, I found this quote from a website of the National Academies of Sciences, Engineering, and Medicine. And it was in a report on a book called The U.S. Health in International Perspectives, Shorter Lives and Poorer Health. And I'm not sure if the quote is actually from the book, it wasn't quite clear, or is it a quote from the person giving the report. But I'm going to read it out loud to you. No single factor can fully explain the U.S. health disadvantage. It likely has multiple causes and involves some combination of inadequate health care, unhealthy behaviors, adverse economic and social conditions, and environmental factors, as well as public policies and social values that shape these conditions. So it's very interesting to look at the problems facing healthcare in the U.S., and there are many, ranging from our lifestyles to our complicated insurance and payment systems, and there are many things that we are going to have to address. Now I'd like to go over to a little bit more of a little bit more personal level. In 2011, I was practicing at Rikshospitalet. I had a wonderful job, as I mentioned a few minutes ago, and I was unfortunately diagnosed with stage 4 lung cancer. And I want to give you a little bit more background and history about what I have been through as a cancer patient. But let me start first. In 2011, when I was diagnosed, I had been married to my husband, Tron, for 15 years. And our 2 girls, they were ages 12 and 9. This picture is actually taken 3 months after my diagnosis, but it was a nice family picture showing the ages of my children and my husband. I had no family history except for a great aunt who had had lung cancer. And I don't believe that she had ever smoked. I had never smoked either. So how was the diagnosis made? I was feeling great. I was doing extremely well until about 6 weeks before diagnosis, when I began to have drenching night sweats. I would sometimes have to change my pajamas 3 and 4 times a night and sleep in the guest room because of the sheets being so wet. But then this went away or became a lot better, and I didn't think so much of it. 3 weeks before I was diagnosed, I was able to go on a 9-kilometer hike in the Norwegian mountains, and I had no lung symptoms. In fact, I never had any lung symptoms, which was very unusual. The night sweats returned. I had some mild fatigue, but I was able to work full-time as a physician. And I had no toxin exposure. Again, I had never smoked. I had never been around secondhand smoke. And I had never worked with chemicals in, for example, basic research. I had always done clinical research. We even checked for radon gas in our home, and we did not find it. I went to a primary care physician and we performed labs which showed elevated white count, CRP, and an isolated ALK phos, which looking back was a red flag. I asked the physician if we could go ahead and do a chest x-ray as a kind of an afterthought, just to cover all of our bases. I thought that maybe I had something like mono. I was not sure. On day 5, after this initial workup, I received a phone call from the physician saying that they had found something in my left lung and I needed a chest CT soon. My colleagues at Rikshospitalet were able to expedite my workup, and in fact, that very same day, my colleague was able to get me into the CT scanner for a chest CT. Unfortunately, a 4-centimeter tumor was found in the left lung with multiple nodules in the right lung, including multiple pulmonary emboli and multiple skeletal lesions. 2 days later, I underwent a PET scan, which showed diffuse metastases. I'll show you a picture of that in just a moment. And I did undergo a biopsy that very day of the lung tumor and also of a bone lesion. Now, this biopsy did show ALK positive lung adenocarcinoma. And before I show you the pictures of the PET scan, I wanted to just briefly touch on what the ALK fusion protein is. And I'm not an oncologist. I'm just going to give a very, very brief introduction to it. ALK is a transmembrane protein which is involved in cell growth and proliferation normally. Sometimes there will be an inversion in chromosome 2 that fuses the EML4 gene with the ALK gene. And so you get an EML4-ALK fusion gene, and it is an oncogene. And this is the protein that is targeted in the treatment of ALK positive lung cancer. It occurs in about 4% of all non-small cell lung cancers. However, in a subset of patients, for example, relatively young patients, if I understood it right, more often female, but that may not be true. But these patients almost exclusively are non-smokers. And about 50% of them will have the EGFR mutation. And of the 50% who were EGFR negative, about 22% of them will have the ALK fusion protein mutation. So with that background for the ALK fusion protein, and this was demonstrated in the tumor that I had, let me go on and show you the PET scans that were performed 2 days after the chest CT. You can see that there was massive metastases all over the body. This, of course, is the left ventricle is normal, and in the kidneys that's normal uptake, but otherwise all of the dark lesions are metastases. The brain, of course, that's not all tumor, of course. That's just because the brain takes up glucose so rapidly. I was immediately started on crizotinib, and this is the first-line therapy for the ALK mutation. It's a tyrosine kinase inhibitor. I had marked improvement and regression only 3 months later, and I'll show you the fantastic response. After only 3 months, you can see that almost all of the metastases were gone. At least they were not active on the PET scan. And here you see the coronal view and then the sagittal view. Unfortunately, crizotinib does not go over the blood-brain barrier. Excuse me. And in May of 2012, I was found to have 12 lesions in the brain, and I underwent gamma knife treatment of these lesions with a very good response. In September of 2012, I unfortunately had progression on crizotinib, and you can see on the CT multiple tumors in the right lung as well as the primary tumor in the left lung, and these were active again on the PET scan. I was immediately referred up to the University of Colorado, where there was a study ongoing using crizotinib, the second-line therapy for ALK mutation lung cancer, ALK positive lung cancer. I underwent a new biopsy to see if I had the new mutation, and I mention this because it has been discovered why patients become resistant to crizotinib. And I did have the new mutation and was then started on crizotinib. Here again, I had a fantastic response, and you see after only 2 months, all of the lesions are gone from the right lung, and the primary tumor has shrunk to a very small size. And in fact, this is thought to just now be scar tissue. You can also see, amazingly, that lesions in my brain also responded. At high doses, crizotinib is able to go over the blood-brain barrier and have a sufficient concentration to treat lesions. You never get the same concentration in the brain as you would peripherally, but at least you do get a sufficient concentration of crizotinib. And I had a very marked regression in the brain as well. Unfortunately, my liver did not tolerate the high doses of crizotinib, and because of elevations in the ALT and AST, had several dose reductions. And I currently am at a dose of 450 milligrams daily. I had excellent control from the neck down on crizotinib. However, I began to have progression in the brain in April of 2013. And at one time I had 15 to 20 lesions in the brain. Therefore, I underwent whole brain radiation in July of 2013. Now, what has been going on since then? I had a great response to the whole brain radiation, and I have very stable, stable conditions in my brain. There are a few white spots. What they are, we are not sure if they are lesions or scar tissue, but they have been stable since then. Now, I had complete control of the cancer from the neck down until May of 2015, when I began to have pain in my back, and we did a PET scan in May, and there were 2 lesions in the T-spine, T6 and T8, and I underwent about a month ago gamma knife treatment to those 2 lesions, and I have no symptoms or side effects from them now. Also, you can see, I just wanted to show you a picture back from the summer of 2013 when I underwent the whole brain radiation. And these lesions that I had, the 15 to 20, they were very small, but you can see that they were growing. And so I did undergo whole brain radiation. Now, what have been the treatment effects? Well, they've been fantastic. This has been just a wonderful treatment for me. I've never even had to have chemotherapy, and therefore my children have never had to see me lying in bed so sick from chemotherapy. I did lose all of my hair from the radiation, but we tackled it. I wore lots of hats, and my children were very supportive, as well as my husband. And you can just see that despite being treated for stage 4 lung cancer, I've been feeling great. I've been able to spend so much time with my family. I've been able to travel. Here we are walking in the Free to Breathe walk, raising money for lung cancer. A year ago in the summer, there was still snow in Norway, and I was trying to hit my husband with a snowball, but I didn't catch him. And here we are, our 18th wedding anniversary on a cruise in northern Norway. And here we are at the North Cape in the northernmost point in Europe. And also here I am with my two precious girls. Now, my patient testimony would not be complete if I didn't share with you the role of my faith in this walk through cancer. I respect all persons and their right to believe as they choose. I personally am a Christian, and my faith is in Jesus Christ. And when this diagnosis came in 2011, I immediately went to my Lord and Savior, Jesus Christ, for help. And so many people began to pray for me all over the world, and I am so grateful for this. And they continue to pray for me. I do not believe that I would be able to speak to you 3.5 years later were it not for the healing that has come from Jesus, and I give him all the glory for it. So I do everything that my doctors tell me to do, but I also have the great physician, and I continue to believe for and to pray for my complete healing. I love this picture because ever since I was a little girl, when I would see the sun shining behind clouds like this, I always thought of it as light from heaven. And so I feel like I'm on a journey, and I just need to keep pressing on, and I'll just keep going forward. And this picture was taken one day when my husband and I were driving from Dallas back into Fort Worth. And I'll just, again, continue on this road that I'm on with guidance from above and also guidance from my colleagues who are treating me. So, in conclusion, U.S. healthcare faces tremendous challenges. We all know that. But also, U.S. healthcare has tremendous potential. And I have just shown you some of the best that American medicine has to offer. And it's exciting what is going on in American medicine, but it's also troubling. And I would just encourage you, please do not give up. Patients like me need you, and we need your expertise, we need your hard work, we need your intelligence. And I look forward to seeing what will happen in the future with American medicine. And best of luck in all of your future endeavors. Thank you.